I'd like to hand over to Thomas Mason from NHS England to talk to us about assessing the effectiveness of the vaccines. So over to you, Thomas.
Okay. Yeah, thanks, John. Hopefully you can all hear me clearly. If not, please do let me know. I'm Tom Mason from NHS England. I have a small team who work closely with me, and our sort of day job is activity analysis for the NHS, largely to support sort of planning functions within the NHS, and also to answer a wide range of ad hoc questions, both on elective activity and non-elective activity. Most people's day jobs changed dramatically with the COVID pandemic, and one of the projects we worked on as a team was to try and assess the effectiveness of, in this case, the Pfizer-BioNTech vaccine relatively early on, when we first got our first cuts of testing data and activity data through based on a sort of a cut of vaccination data. So as John's mentioned, within NHS England and Improvement, we have access to quite a wide variety of record level, individual level data sets, and with the rollout of the vaccination programme, we were able to identify individuals as they were being vaccinated, and we could link those vaccination events to elements of their secondary care data use. And the idea has been to try and understand how vaccination has impacted test positivity for COVID and also hospitalisation for COVID. So that's what today's presentation is about. And as per the title, one of the things about this is it initially sounds a relatively straightforward task to be able to see how effective vaccines are, but actually it's a notoriously challenging area in terms of some of the biases that persist. And if you are interested in the effectiveness of vaccination, you may be aware that quite often very high efficacy figures are floated around, sort of 90+%. And what we'll show today is that to some degree, those very high efficacy levels are correct, but they're correct in what they are measuring. And in the real world, vaccine effectiveness, which is what we're looking at here, isn't quite as good as the headlines might want us to believe they are. So I'll get going, and hopefully my slides will move forward. So when we started looking at this, we were sort of tasked with doing this back in January. And at the time, you may be aware, vaccination programme started on the 8th of December. And actually, it got off to sort of quite a fanfare, but there weren't many people vaccinated during December. And the real sort of large volumes of vaccinations started to be given from sort of the second week of January onwards. And this is what this chart is showing. You'll also be aware that the vaccination programme has largely been rolled out on an age criteria, with some sort of extra vulnerable groups slotted into that programme. So the very first people to be offered vaccinations were the over 80s. So given this, we designed a study to help constrain the problem. We looked at people in their early 80s, in this case 80 to 83 years, who were vaccinated early on in the programme. So in this case, we're looking at between the 15th and the 20th. So if I zoom in down to that group, so the blue bars there are the individuals we looked at. And we followed those 80 to 83-year-olds through for our monitoring period through until the 3rd of February. So we sort of looked at what their outcomes were in that time period. And what we wanted to do was get a control we could compare our vaccinated individuals to, and use that control to effectively do a pairwise control matching approach. So we could basically look at the outcomes for our vaccinated individuals and then the outcomes for our controls, and then the net difference between the two would be vaccination effect, as long as the controls are comparable to the vaccinated individuals. Now, one of the benefits of the way we had an age-related rollout program. And one of the reasons we look specifically at the 80 to 83-year-olds is that very few people in their 70s were actually vaccinated until later on in the program. So people aged 76 to 79 largely went unvaccinated until mid to late January. So that gave us a sort of period where we could follow through our 80-year-olds, and if we matched them to someone just slightly younger than them, we could effectively monitor outcomes without some of the problems which we'll go on to talk about fishing from the same pool. And what I mean by fishing from the same pool is you might have said, well, why don't you just pick another 80-year-old who isn't vaccinated and then use your unvaccinated 80-year-old to your vaccinated 80-year-old and use that to monitor your outcome. The problem is, and it's shown by the blue line on the chart, I'll see if I can hover over it, over the period that we're monitoring, very rapidly, we'd actually vaccinated the vast majority of 80-plus-year-olds by the end of January. So what it means is if we were to select our control out of the people who are left who are unvaccinated, actually that pool who haven't been vaccinated, there may well be a good reason why they're not vaccinated. So actually what we wanted to do was actually use the black line here, which is, as I say, the 76 to 79-year-olds, which gives us more time to monitor outcomes before the biases associated with taking patients out of that selected pot we could use as controls comes in. And I'll talk more about that, but it's actually quite key to our study design. So here we're looking at 80 to 83-year-olds who are vaccinated, and we're comparing them to 76 to 79-year-olds who weren't vaccinated. In terms of the actual study design itself, I'll just go through the flow diagram. So 73 million or so adults in England in mid-November. As I say, if we go down the left-hand branch of the chart in front of you, this is the vaccination arm. So there's about 1.6 million individuals, 80 to 83-year-olds at the start of the period. And of those, about 172,000 went on to have their first dose in that 15th to 20th of December window. So that's our pool of vaccinated people we're interested in. And as is often the case, that pool, there were some people in there we wanted to exclude for quite valid reasons. So we chose to exclude care home patients because there'll be different transmission risks in care homes than there would in private dwellings. So that knocked a few out. And then we also wanted to ensure we were removing patients who had a prior infection from COVID, because that could impact their chances of developing COVID again. So we excluded patients we knew about who had had COVID previously. So that gave us about 170,000. On our sort of potential pool for the matching process, about 2 million individuals in that 76 to 79-year-old group. Very few of them were actually vaccinated early on anyway. And again, we excluded some care home residents from that group, and we excluded those that had COVID. So it gave us about 1.9 million individuals to select our controls from. But it's not quite as simple as that. So in the design methodology that we used, what we wanted to do was use a pairwise approach where we have a vaccinated individual and we search the data we had for another individual from a data perspective looked near identical to them. So for this, we used an exact matching approach on a number of criteria which are listed up in the top right-hand box here, sorry, top left-hand box. So we've already mentioned they shouldn't have had COVID in the past. We matched on gender, area of residence, and here we used middle super output area. We also corrected for, or we included small area deprivation at quintile level, or was it actually quartile level, I think, sorry. We matched an ethnic group. We had a classification of health status, which was frail, living with comorbidity, or healthy. We had a classification for living arrangements, so people living on their own, people living with children, people living in other living arrangements. We included whether someone had had a seasonal influenza vaccine in the last year. The idea there being that that might give us some sense of individuals who were sort of willing to be vaccinated against those who weren't. And then we also had something about their non-elective bed use in the 2 months prior to vaccination. And I'll talk a little bit more about that in a bit. So we essentially ran an algorithm which identified for every vaccinated individual a control that met all of those criteria. And that took us down from about the 171,000 down to 131 or 132,000. So we effectively had a vaccinated individual and a control for all of those individuals. There were a few extra exclusions, I should say, so we knocked out another 688. So we wanted to avoid residents living in the same address, just in case they infected each other, and equally patients who were in hospital at the time of vaccination. So they just took out a few extra, but essentially we're looking at about 100, just shy of 132,000 individuals we had matched pairs for. Now, and we could do the same, obviously we follow the same sort of process to get our controls. Now, if I explain a little bit more about how we got that data set together. So as I say, within NHS England and Improvement, we're in a relatively fortunate position of having access to very granular record level information from a number of systems. And we knitted together what we call the immunization data mart, which is sort of represented in the middle of this diagram. And it includes, at an individual level, it has a record for every individual registered with a GP practice in England, and we have information about their demographic characteristics, their geographic attributes, their health status, I've talked about already, whether they are frail, whether they have comorbidities. We can also pick out from this, from an address analysis, their living arrangements. So we know, as I say, if they are living alone, living with children, got other information about population. We didn't use it for this evaluation because everyone was elderly, but in the data we can also identify NHS employees and a subset of whom are frontline NHS workers. We incorporated in here mortality, information on vaccination history, secondary care usage, which I'll also talk about, and then probably equally important, COVID testing status. So we were able to link in to that data mart or positive COVID tests. And these are the data sets that feed that data mart. So we have extracts from what's called the NHACE system. So these are extracts taken from GP systems on who's registered with GP practices. We have extracts from the National Immunization Management System, which is telling us everyone who's vaccinated, what vaccine they had, when they had it. COVID positive test information that comes from Public Health England, that tells us when they had their swab taken, what type of test they had, and there's also information there on variant type as well. Mortality records, so coming from ONS on when patients registered having died. I mentioned about the employment status information that's coming from the ESR system, electronic staff record. These are sort of where we got the hospital usage data from. So we linked through to emergency care data set to get A&E attendances via ED. And we also linked through to the admitted patient care CDS from the SUS service to get more granular information on hospital stays. For the work, we had access to an ethnicity register from NHS Digital, which was telling us about more granular details and sort of validate information about individuals' ethnicity. And then finally, we had information again from NHS Digital on what's called a shielded patient list. So this was used to prioritise people at risk for vaccination. And again, that came through. So that's just a quick run through of some of the data sets we used and how we knitted those together. With all of that data, I've already touched upon the matching algorithm we used. And in part, we developed the matching algorithm in a relatively pragmatic way to try and balance how many matches we got to the sorts of factors we expected to influence exposure risk to COVID and subsequent people developing COVID. As part of the study, we also ran Omnia and my team ran a logistic regression model just to check that the various factors we used in that matching algorithm were coming out as significant. Admittedly, not all of them were coming through as significant, but quite a lot of them were, and the interesting ones that were coming through. So living alone had an association, in fact, had a weaker association with developing COVID than other living arrangements. Health risk was quite important. So frail individuals had the higher risk, and then clinically vulnerable people next. So I've put this in really to illustrate that as part of the study, we were able to demonstrate that the way we did match our controls to our vaccinated individuals, there are clear associations in the background there that justified that linkage approach. And from it, and I'll just go to the next slide, the other way we validated that our matching approach was justified was to simply compare historic healthcare utilisation for our pairwise vaccinated group and their controls. So in this diagram, the blue hollowed out line is showing what the activity is for our vaccinated group, and then the orange line is what the activity is for controls. And we've got A&E attendances, non-elective spells, elective spells, and outpatient attendances. So this actually runs to sort of early December, which is when the vaccination program started. So it's essentially looking at what the 132,000 individuals we have in our sample, what was their healthcare utilisation like? And it illustrates that they are remarkably similar. So this gave us, again, confidence that from a data perspective, our controls and our vaccinated groups looked very similar. Those of you with eagle eyes may sort of notice that the elective charts have slightly higher elective activity for the vaccinated group. We've attributed this to the age effect. So if you remember, we're matching here 80 to 83-year-olds to 76 to 79-year-olds. So that 4-year age gap we on average have will inevitably mean that these patients have higher healthcare, are older and have higher healthcare utilisation, which explains to some degree why we're seeing that difference. But we weren't overly concerned by that difference. We thought these data demonstrated a relatively close match between the control pool and the vaccinated pool. So, so far so good in that we've got a vaccinated group and we've got a control group, and then we can compare the two and we can monitor outcomes. When we started to do this work, we started building all of these processes before we'd sort of got our complete monitoring periods data available to us. So we were essentially sort of running this on a daily basis and looking at what the results look like, refining our algorithms, building it as we went along. And what we noticed when we were doing this was that our measurement of effectiveness, comparing, in this case, positive tests for our control against positive tests for our vaccinated group, we're finding that every time we reran it, we've got more data, we reran the model, we're finding the gap, the effectiveness, kept on getting bigger. And we got ourselves sort of a bit confused about what was going on. Why was, every time we ran it with more data, why we were getting a different effectiveness measure to when we'd run it a few days before. And it became apparent when we looked into it that what's actually happening relates to the fact that our controls shouldn't have been vaccinated during our monitoring period. So we have a a rule in our logic which says a control can't have been vaccinated during the monitoring period, because if they had been vaccinated during the monitoring period, then they aren't a true control. They may have some vaccination effect associated with them. And then what we found out was, as we sort of extended our monitoring period, two things happened. First of all, the eligible pool of controls keeps shrinking. It keeps shrinking over time because, and it'll come on to the next slide, because of this ramping up in the black line. So as we've vaccinated more and more 76 to 79-year-olds, what it meant is the pool available to select our controls from keeps shrinking and shrinking and shrinking. So we have that effect going on, which means we're getting fewer matches. So as I said at the beginning, we have 132,000 vaccinated patients we could get a match for at the beginning, but over time that number diminished. It shrank because the pool we had available to us to select our controls from was shrinking. But actually, not only was that going on, there were sort of two associated effects with that shrinking. First of all, when we're matching on a whole range of parameters, and some of those populations we're trying to match to are quite rare or small in number. So an example being some of our ethnic minority groups, they're relatively small in number in the population we're looking at. So as you vaccinate more and more people, those pools contract to the point at which they completely drop out of our matching algorithm because there just aren't the people there to match to anymore. So there's a bias introduced by the fact we're not matching to some of the more hard to reach groups, if that makes sense. But another factor that's going on is that not only are we vaccinating people during this period, so they're coming out of our potential control pool, simultaneously, those people in the potential control pool, some of them will be getting COVID. And you have to remember, this was January time when we were going through a significant wave, equally as big as the first wave of COVID. So there's lots of COVID around at this time. And patients were getting COVID. And because they were getting COVID, you have to be COVID-free to be vaccinated. So there were individuals who would have been vaccinated, but they got COVID, and then they ended up staying in the control, well, the pool potential that we could select our controls from. So over time, not only was that pot diminishing, the pot was then getting concentrated in individuals who had COVID and hence hadn't been vaccinated. So if I go to the next slide, this will help to illustrate it. So what we're looking at in this slide is a bit messy. So I'll talk through it. That the top chart, top left-hand chart, we've got here total positive cases, and in orange we've got our various controls, and in blue we've got our vaccinated group. And what we're effectively doing is we're extending the monitoring period a day at a time, and by extending the monitoring period a day at a time, each day we extend it, our pool of potential controls shrinks and gets more concentrated in COVID patients. So each of these lines represents a different snapshot of our potential control. And as you move along, generally you go up as you extend the monitoring period. So these orange lines at the top are for our longest monitoring period, where our control pool is smallest and most concentrated in COVID cases. So when we were doing this is exactly what we were seeing. We kept on sort of comparing the blue line down here to the orange line that reflected that point in time and getting a bigger difference each day we were doing it. And it, as I say, we unpicked this and recognized this bias. So what we then did was we developed an adjustment for it where we stepwise take back each day's values to the day before. So essentially what we're doing actually is we're collapsing each of these lines down onto the line from the day before. And that's how we arrive at the chart on the right-hand side. So now you see that we had this big variation. We've collapsed it down, and essentially the dashed line represents the last good point for each day that we've estimated. And what we're actually wanting to do here is, in this case, looking at positive COVID cases. We're looking at positive COVID cases for each day in our control, the orange line, dashed line there, to our vaccinated group, the blue line there. And actually it's that net difference between the dashed orange line and the dashed blue line that's the effect we're looking for. So you can see how that axis has collapsed down from 300 down to 50. So it shows the degree of sort of concentration we're seeing here. And it's very stark, but it was effectively leading to some quite erroneous results. And we saw that there's the same effect both with positive cases and also with hospitalisations. But we managed it actually in two ways. So I've talked about this adjustment methodology where we stepwise back each day and collapse that data down onto itself. The other way we approached this was we said, well, actually, as we were doing the analysis, it became apparent that the effect of vaccination is delayed. So if someone's vaccinated, they don't get protection the next day. And generally speaking, they're not really seeing observable protection until around day 14. So knowing that, we sort of got 14 days to play with before we can start to monitor vaccine effectiveness. What we said was, well, why don't we allow matching to individuals within that 14-day post-vaccination period? So, and we'll just go back here. So the point to recognise here is that by moving 14 days, we can shift that whole black line over by 2 weeks. So it gives us almost 2 weeks extra monitoring while limiting the bias. So actually what we ended up doing in practice was we did both of these steps. We extended the window we allowed matching for to that 14 days, and we applied the adjustment. And that's where we arrived at in a sort of final methodology. So if I now look at what the results actually look like, which is in a way what I suspect you're most interested in with this, I mentioned we looked at 3 outcomes. Test positivity, so because people go on to have a COVID positive test, A&E attendance via ED, so admission and A&E attendance, and then we also looked at admitted to hospital with COVID-19. So just to explain what these charts are showing, day 0 shown, it's not on day 2, but effectively day 0 is the day of vaccination, and this is for the vaccinated group, which is in blue, how many people tested positive as a rate coming up here, rate per 100,000 per day, and then the orange line is the same for the control. So essentially we're monitoring over time here how many individuals went on to have a positive test in the control and the vaccinated group. The middle charts are just showing that cumulatively. So this is quite useful because it sort of shows the profile. This is sort of showing how they diverge. So the blue line is lower. And then this is then showing the net difference between the two. So this is giving you a sense of the percentage effectiveness, if you like, of vaccination. So if I remember, sort of zoom in. So again, you can see that profile. Error bars are sort of, I should point out how we did the error quantification. Within this methodology, we used bootstrapping methodology to effectively propagate errors through our model. So they gave us those confidence intervals. That was quite a pragmatic way of measuring confidence, but it does mean that some of our error intervals are larger than maybe some more classical approaches for doing this using survivor analysis. So if you are looking at these results and thinking you've got quite big error bars, it's because we've used bootstrapping quantify those error bars. But as I say, we can see there is a clear difference, and they are distinct, particularly from around day 19 onwards. We see a significant difference there between the control and the vaccinated group. And if I zoom over that again, you see here that sort of day 18 or so becomes significant, and we're sort of settling for positive tests somewhere, I'll go and see exact figures in a minute, but somewhere around 70%. So vaccination in this case appears to be reducing positive cases in the 80 to 83-year-olds, I should point out, by about 70% or so. Now, another point to recognise, which I haven't touched upon, is that one of the reasons we selected the period we used for the study, which is the 15th to the 20th of December, was these individuals were all on a 2-dose strategy of the Pfizer-BioNTech vaccine, and 80% of them did go on to have both jabs in and around 21 days after their initial jab. So what you're looking at here is effectively the effect of a 2-dose strategy of the Pfizer-BioNTech vaccine. If we'd have extended that period, we would have actually been moving into individuals who had predominantly one dose, because that policy change happened around the sort of 21st, 22nd of December. So when you're looking at these results, just bear in mind this is for 2 doses, not a single dose, and it's also just for the Pfizer vaccine and just for elderly patients. And then if I look at hospitalisations, we see a similar sort of profile, smaller numbers here, so a little bit more erratic, but again, actually, when we look at the effectiveness, we're actually getting a slightly larger average effectiveness here. And I believe the next table summarises the results. So the neat thing about this approach is we can look at effectiveness at different windows, so 14 to 20 days, 21 to 27, 28 to 34, and 35 to 41 days. And if I focus on these sort of final results, key points to note here are effective against positive tests for about 70%, effective against hospitalisation of about 76%. But these confidence intervals, you'll notice, are quite wide. So there is some variation in this. And actually, when we've compared our estimates to what, at least what was in the public domain when we wrote this work up about a couple of months ago, our estimates for elderly patients were broadly in line, well, at least within the confidence intervals of other studies at the time. So these weren't out of kilter with other studies, but they are generally a bit lower than other studies. So I'm sort of bringing this to a close now, but we have written this up. At the moment, it's still with peer review, with I'm trying to think who it's with, BNC Medicine, I think. We sort of initiated the project internal to NHS-CNI, but actually we had quite a bit of support, particularly in terms of writing this up and refining the methodology with Matt Sutton's team from the University of Manchester. So the sort of things we've talked through here have gone through that sort of more academic rigour, if you like. And as I say, this preprints available through MedX on the web, and we can share. Those of you who screenshot that, there's the links up there, but obviously the slides will be available afterwards that you can follow this up as well. And the paper goes into the detail I've spoken to on the presentation today. And in a way, what we try and sort of tease out in this paper is actually some of the biases we've observed associated with, particularly with the concentration effect of COVID positive patients in our control. Various studies make fleeting reference to the various biases that exist, but it is an area that is actually to some degree not necessarily given the transparency it needs. So if you are reviewing the literature, looking at vaccine effectiveness estimates that are out there, quite often they aren't detailing some of the biases that could impact their measurement. And I think it's an area actually which is not necessarily fully understood, partly because it's very rare that we have interventions that are rolled out at population level in the way vaccination programs are. So it's very rare that you're getting up to 90% coverage of vaccination, which means your control pool is significantly impacted. And if you take anything away from today's presentation, I think it's to be aware that when people talk about vaccine efficacy and vaccine effectiveness, not all of the studies that are being quoted in the press will necessarily have accounted for all of the biases that sit behind it. And I would argue there are still inevitably biases between our control and our vaccinated groups in this study, but the study design, in the way we've looked at a very specific age group, we've exploited a change in policy, or a policy around age that gives us more time for a less bias evaluation, means that we are, to some degree, probably as pure as you can get in trying to make this measure. And it's just, as I say, I'll leave it there and I'll open up to questions. And I will just come out of the presentation so I can see Teams. So is that all okay?
Yeah, that's brilliant. Thanks very much, Tom. It's a really interesting presentation. It's an interesting case study in how to use admin data and to you get to the heart of the matter with real data. And I had a couple of questions. I've seen that we've had one question that's just popped up in the chat bar, and I just to remind everyone else, if you've got a question you'd like to raise, do feel free to put that in the chat bar, and we'll pick that up. I wanted to, as you worked through and I was looking at the slides, I just wondered whether on the graphs that show the difference between infection rates for the control group and the group that had the vaccine, I was quite surprised that they started with a big gap at the left-hand side, and I wonder whether there's anything there that you'd have to look into in a bit more detail.
As to say, I'll zoom through the slides and I'll get to that bit. Yeah, so there are some interesting effects going on, which we haven't really covered in the presentation. And to be honest, we found it quite difficult to test for them. But you're right. So I think you're getting to, if I zoom in actually, you're getting to the fact that the controls are starting higher than the vaccinated group down here. So you may expect both the orange bar and so the orange is the controls and the blue is the vaccinated group. You might expect them to start at 0 and then both grow from 0. But actually what I've sort of mentioned it, one of the biases we have in the data is that to be vaccinated, you have to be COVID-free for 14 days before your vaccination. But to be in our control, you don't necessarily have to be. So our controls could have had COVID, but they essentially the blue line is depressed because we're excluding anyone who's come into contact with people in and around that vaccination date. So if for example, you were due to be vaccinated, but then someone in your household got COVID, you may well have not gone for vaccination. So it's leading to a systematic bias where in the early period we're low, because to be in this blue line, the chances are you have been COVID-free and your household has been COVID-free. Whereas you could be in the orange line. Admittedly, you should be COVID-free at the beginning if you are in the orange line, but your household might not be. And then, of course, you could get COVID straight away. So essentially, it's illustrating that difference. But there are other things going on, and the challenges of the testing data is quite different to the challenges of the hospitalisation data. And I think it's broadly recognised that the hospitalisation data a bit more complete in what it's measuring, i.e. it's just measuring people with a medical need who have COVID, whereas the testing data is more measuring people's willingness to be tested or to put themselves forward for testing. So there are some strange potential biases going on early on as well, where the symptoms of having the vaccine could make someone more likely to get a test, or equally less likely to get a test. Because if someone is told they might have a fever, might have COVID-like symptoms a few days after vaccination, they might not go on to get tested, and they could actually have had COVID. Whereas in the orange group, you don't have that same effect. So with the testing data, there are some nuances going on, particularly early on, that can explain or could be used to explain that gap. We found it difficult to properly test it in our study design, but it's to be aware that that gap may be explainable by some of those biases that are going on early on in the time series, and the fact that these are actually converging is suggesting that those biases are diminishing. And I think if I'm right in thinking, for hospitalisations, the gap is less. I mean, it's a more noisy data series, and there still is a gap, but it's less, and they do converge, and then they cross over, and then we see vaccination effect kicking in. Does that answer your question?
Oh, it does, yeah. Yeah, that's excellent. I'm trying to work out in my head whether there's any way of looking at the sort of the test positivity rate rather than the case rate, because it's a common problem with COVID testing data, isn't it? Yeah. That we're doing more testing, so cases go up.
Yeah, exactly.
The point of interest is often the positivity rate.
Yeah, and I mean, we obviously utilised the administrative data we had to hand, and one of the reasons I suppose we were able to run this quite quickly was we were fortunate in having access to those administrative data sets. There is lots in the public domain now on vaccine effectiveness, and some of the probably most robust estimates that are out there are based on the cohort studies that are going on. So so the ONS infection survey, and there's an Oxford Simon study as well, I believe. They in a way can be more like or they can control for these things in a clearer way than we can. So they don't have the same size. I mean, the benefit we have in this study is that we are looking at 132,000 cases. So we've got a lot of cases here, but we equally have these sort of biases in that, again, when you look at tests, where some of those other studies, they're regularly testing their the cohorts that they're following. So they don't have those same test biases that we have here.
That's great. So I wanted to bring in the question from Kim Johnson. So yeah, I agree, interesting and thorough work. So who was involved in your team, and how did you manage to run the project? Yeah,
so I have we're quite a small team. There's 5 of us at the moment, and there were elements to the study that were data management, so bringing together the data mart I talked about, and doing some of the programming to automate the matching process. So Matt and Jack in my team are both pretty proficient in SQL, and Matt did a lot of that SQL development. So that's sort of data engineering, if you like, using SQL. And then Jack did a lot of the R. So the actual mechanics of what we did here were sort of a hybrid of churning the big data sets in SQL and then processing and generating the outputs in R. And Jack did a really good job of doing that R processing. So when I talked about that stepwise adjustment methodology, that was all developed in R and implemented in R. And R had the real advantage that we could implement the bootstrapping sort of statistical approaches as well. So it's worked really well. Since we sort of initiated the work, I mentioned we worked quite closely with Matt Sutton's team from Manchester University, so they brought a lot of constructive criticism into that process and helped us sort of make the process more robust. And equally, were really helpful in actually writing it up. So writing academic papers isn't something my team do a lot of, but Matt Susson's team really helps shape this into an actual scientific study and a scientific paper rather than something we might have written internally. And the sort of the nature of our work, particularly since the COVID pandemic, is that we sort of balance short-term projects with our day-to-day sort of standard reporting functions, and then the more ad hoc stuff that came in. So it was balanced. It was balanced, and I think as a team we certainly did more work than we were contracted to over this period. It was a very intensive period in terms of how much work we did, but it was a very rewarding piece of work, and I'd hope the team would feel that as well, in seeing it coming together and actually getting some of the first estimates of vaccine effectiveness out. Was really rewarding. Not something my team would ordinarily do. It's more something we rose to the challenge of, given the circumstances at the time.
Excellent, thank you. So I've just seen that Jack has posted in the chat bar that people want to see the SQL and R scripts that they've been published on GitHub. There's a link there. A question from Kamarul Imran Musa. Any opinion on the suitability of propensity score matching as an alternative approach?
Yeah, absolutely. And actually, some of our colleagues from the economic team in NHSEI have done some work exactly on this. So there are pros and cons to a lot of what we did, and one of the exact matching methodology we used has the benefit of being quite transparent to some degree in how we're identifying patients who are, on paper at least, are very similar to their match. But the downside to it is we've got attrition in our matching. So I mentioned there were 172,000 people vaccinated in the period of interest, and we only had match controls for 132, so about 70%. So effectively, we've got an attrition there of about 30% of cases. Now, because we had so many cases to work with, that attrition rate wasn't really a concern. But equally, but if we were looking at a much smaller study where that attrition was of concern, then exactly propensity score matching comes in. I'm not an expert on exactly when to use propensity score matching and when to use the sort of exact matching approaches we've used here. And ultimately, I suppose the interest is in seeing just, does it make a material difference to your results? I would hope it wouldn't. We did a little bit, I didn't touch on it, but we did a bit of sensitivity analysis. We talked about using bootstrapping to quantify our errors. We also ran our matching algorithm 5 times, and arguably we should have done it more than 5 times, but there's a diminishing benefit actually in resampling, because we were doing it quite often. There was only one individual in a subpopulation that we could get the control for, so actually resampling multiple times would have actually ended up as just picking the same individual multiple times in many cases. So we did some work to quantify the uncertainty associated with a matching algorithm, but there's always more we could have done, and propensity score matching, I think, is a valid way of looking at this.
Thank you. I just had one more question. I'm not quite sure how to phrase it because it's quite general. And so obviously you're working in a national administrative organisation in NHS England, and doing work here with effectively individual level patient data. And I just wonder if you had any reflections on the benefits of having access to that data, and whether there are any challenges in getting the information governance lined up to be able to do it.
Yeah. So one of the say powers is the wrong word, but to support the COVID response, there was NHS Digital released a sort of a set of rules which are effectively known as COPI, which cover, in fact, it may have been NHSX to be honest, but they effectively facilitated person level linkage for the purposes of COVID analysis and reporting. So under that COPI notice, it effectively allowed us to do linkage across a wide range of data sets that ordinarily would have had to have made a much stronger specific case to do. So I strongly believe that if we didn't have COPI, we would have navigated that because there's a clear benefit to understanding vaccine effectiveness. But the COPI notice almost accelerated the ability to do that work. And personally, I think the ability to link data in the way we have been able to understand the spread of COVID and to the response to COVID and the effect of the vaccination program and the rest of it, it's been hugely beneficial. And we are still working. It should recognise we are still constrained in how we can work with this data in protected environments. We can't copy any of it out of the database that we're granted access to. We're all monitored and audited. So there's still a lot of information governance controls and data protection controls in place. But what it did do is it alleviated or reduced the need. We didn't need to put in bespoke justifications for what we're doing and then go through a bespoke IG request to do this piece of work, and that really accelerated it. And actually, I think it's understandable why there are processes and checks and balances in place for how we work. But before COVID, the direction of travel the organisation was moving along was one of quite bespoke applications to do pieces of linked analysis where the data set could only be used for that purpose, and you could only get access to the data items that you could justify having access to do that piece of analysis. And I think what the challenge that often has is that with data exploration, and some of this was data exploration, you don't know at the beginning of the process what data items will have value. So you either list everything and then get criticised for asking for far too much, or you limit your request and then end up missing stuff that could be of value. So I think what COPI's demonstrated is actually if you are more pragmatic about the ability to link data where there is a justification for doing so, and you effectively have the controls in place to ensure the data is managed in certain ways, but equally you trust people and you trust analysts that they're not out to use the data in malicious ways, we can get some really good analysis done. And I do fear that we may revert to where we were, in that we sort of have quite a bureaucratic process which adds barriers, and analysis doesn't happen because people don't have time to navigate those barriers. And that's my slight fear. So if there are learnings from the COVID response, I would hope it would be around the fact that we can demonstrate significant value from the data we hold, and if we can find pragmatic ways to make it accessible and linkable, I think we can continue to get those benefits. And I would like to think we don't revert back to a very protectionist approach, which means we often don't do analysis because it's just too hard to navigate our way through that system.
Yeah, that's great. Yeah, no, I think that's. I agree with you. I agree with your summary. I think it's the way and respond to that. I think, in a sense, it's the whole presentation is a very useful use case. It just makes the case that if you have access to these data, you can do some really useful things that help to tell us things we didn't know before, which is a good focus for any health research, I think. I don't think there are any more questions in the chat bar unless anyone else wants to. another question, and it's just coincidentally coming up to 3 o'clock. So I think what I'm trying to do is just to say thank you to Tom and to I know your colleagues are on the line as well. So thank you to all of you for some really interesting and fascinating work, and for a really valuable and excellent presentation.